Ryan Stanton here with ASEP Frontline and with our guest, returning guest. I think you're making a run. I think you're definitely the most visited guest on the podcast, Dr. Christina Shenvi, and one that we turn to often for education related topics and connecting with residents and talks and those types of things. But today, a little bit of a thicker topic in terms of what we're talking about. I mean, anytime you're talking about anti-amyloid therapies and risk of ARIA, yeah, we're getting into it. We're diving right in. And so the anti-amyloid therapies for Alzheimer's disease, and some of the things in terms of us considerations in terms of the emergency department. And just to give you a little teaser, these anti-amyloid therapies are indicated in being used jumping in for some of the early Alzheimer's cognitive decline patients. And of course, what we're seeing with the stress and strain and emphasis on the stroke programs and things like that, if somebody comes in with stroke-related symptoms, there are some considerations for us here in the emergency department. So it's not something where we think you're going to be getting out your green pad and writing out scripts left and right for anti-amyloid therapies, but it is something in terms of the potential changes with that we need to consider. So Dr. Shenvi, thanks for joining us once again right here on the podcast.
Thanks, Ryan. I'm glad to be back. And I became interested in this topic through my geriatric EM work. And to kind of cut to the chase, we're going to talk about what emergency physicians need to know about these anti-amyloid therapies. Because yes, we will not be prescribing them. They are they're infusions that have to be given regularly. Patients have to have close workup and follow up with a neurologist, and they have to get regular MRIs to look for some of the features that we're going to be talking about known as ARIA, or amyloid-related imaging abnormalities.
All right, so that's a new one for us. So the ARIA, not the hotel that we see in Vegas, but the changes we're going to see potentially in the consideration thereof. And you mentioned the MRI, and you did send me some information beforehand, before we started. Baseline, the MRI is the monitoring that they're going to see before the initiation of treatment, before the 5th, 7th, and 14th infusions. So getting into that first year, so multiple imaging studies throughout the year. So theoretically, if they fall on the schedule, we should be able to see if some of these changes are taking place. So kind of break down that definition of ARIA and what that potentially means for stroke-related care.
Yeah, so ARIA, amyloid-related imaging abnormalities, are some findings that you can see on MRI pretty frequently for patients who are receiving these infusions. So the medications are monoclonal antibodies against amyloid or amyloid-folded proteins. And the names of them are lecanemab and donanemab. Those are the two that are out currently. And about 10 to 30% of patients will have ARIA abnormalities on their MRIs. And most of the time, it's asymptomatic. So, but hold tight, I'll explain why it still matters to us. So, ARIA happens as a result of basically the monoclonal antibodies are attacking the amyloid, binding to the amyloid, and it can cause some inflammation and changes. And there are two forms of ARIA: ARIA E, which stands for edema or effusions, and ARIA H, which stands for hemorrhage. So in ARIA E, you'll see on the MRI, and these tend to require some kind of specialized MRI features or sequences. So mostly you'll see ARIA E for edema on your FLAIR MRI. And so this is causing some brain swelling. Again, most of the time, completely asymptomatic. You're just finding it on the MRI. The other one, ARIA H, you'll see this on your GRE or SWI MRI sequence. These are microbleeds. This now, you can see why we would get a little bit more concerned, because say somebody comes in with a stroke or maybe a stroke mimic, and you're considering TPA. Well, if they have this ARIA H or ARIA E, but especially you can think about these microhemorrhages, you can see why giving them thrombolytics could then lead to a larger intracranial hemorrhage. And the challenge right now is we don't have a lot of data. We don't have a lot of numbers. And most of this is falling in the category of case reports where, oh, a patient came in, they had been on these monoclonal antibodies, and they received TPA and then had a head bleed. So there aren't great guidelines or data. However, we can at least think through what would we need to do, for example, if we have MRI or we don't, and then how can we counsel the patient. But the key thing so far to know is ARIA is occurring in 10 to 30% of patients who are receiving these monoclonal antibodies, and it's usually within the first 2 to 6 months of treatment. So if they say, no, I had it, a year ago, then they're probably not going to have ARIA. And most of the time, it's asymptomatic. It's only symptomatic in about 1 to 7% of patients who are receiving the monoclonal antibodies.
All right, so this is a sneaky trap, and we love these in the stroke world, these no-win situations for the emergency
Hmm.
physician. And especially we're talking about thrombolysis. We're bringing folks in with a stroke-related syndrome. Everything's getting pushed now. It worked all weekend, and we're bringing in everybody, every old person who has any level of confusion is getting stroke alerted and sent back. And, of course, everything's hurry. Get them scanned within the
Hmm.
15 to 20 minutes, get it read, try to get thrombolysis initiated within the hour, within 45 minutes, ideally. All of these things are hurry, 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 hurry. But now we're throwing this curveball. We're used to seeing, are you on any form of anticoagulation, one of the DOACs or one of the warfarins, whatever it may be? Are you on one of those that automatically disqualifies you at this point for thrombolysis? I assume this has not been integrated thus far into the stroke workups as a relative contraindication or absolute contraindication. So for emergency physicians who are in this hurry up so you don't get emails the next day, and so the hospital can hang a cool banner on the outside of the hospital that says they're a stroke center, how do we integrate this coming in, and what do we need to look for, and how do we decrease the risk to patients while improving or increasing or making sure those that need to get thrombolysis get it?
All right. Well, Ryan, I'm going to first take us from bad to worse, because some worse news is often these medications are not listed on the patient's home meds list. So, yes, we always are looking for, are they on warfarin? Are they on a DOAC? These medications are infusions that are given at a clinic, so they're not often going to appear on a patient's home medication list. So, first, we would have to ask them. Second, the general recommendations currently, and this is a rapidly evolving field, so I want us to hold this lightly with an open hand. The general recommendations are that we should not give thrombolytics to patients who have evidence of ARIA on their MRI. Now, what does that mean? Well, that means you would have to get an MRI before you can make a thrombolytic decision. Many EDs do not have MRI capabilities, especially maybe don't have MRI capabilities that you can get within the TPA window or the thrombolytic window. So it is a challenge. And I would say if you have MRI capabilities, then try to at least get an MRI as quickly as possible to see if there's evidence of ARIA, meaning those edema findings or microhemorrhages. And we need to get a specialized type of MRI, which I can tell you what that is. And for facilities that do not have MRI capabilities, the current general recommendations are to not give thrombolytics to patients who have received anti-amyloid treatments in the prior 3 months. However, if it's a really severe stroke, a high NIH stroke scale, the quality of life is not going to be good for these patients, then I think it's reasonable to have a shared decision-making discussion with them to say, look, you're on this anti-amyloid therapy. There's a much higher risk, or we don't know what the higher risk is. I can't say really much, but there's a higher risk potentially of hemorrhagic conversion to an intracranial hemorrhage with thrombolytics. However, given this is a high NIH stroke scale, it's very disabling, you could have some shared decision making. So this is not a very satisfying answer. I will recognize that. But this is kind of the predicament that we're in right now.
I mean, that's even the challenge even more is the reason they're on the medication is for cognitive decline associated with early Alzheimer's disease. So can we truly informed consent these patients, especially when you're going to throw in there a significant debilitating stroke symptoms, which could further alter them? So hoping that you have some family nearby that can understand and do an informed consent. But I agree. It's going to be near impossible because of the timing. Very few places. Mine's one of them. If we do a stat MRI, we can get it done. But getting them in there. A number of folks that have some sort of pacemaker, nerve stimulator, something
Hmm.
else that's going to delay that. I mean, it seems like it's going to be near impossible to get the amount of details and then still get somebody within that thrombolysis window um, in order to get the quality outcomes. What's the role potentially of these pre-screening MRIs? I mean, that to me, that sounds like the one opportunity that you may have to actually catch this before is if you happen to be the facility where
Hmm.
they're doing these screening MRIs and they are available there, can that be used if on that fourth MRI or whatever in the treatment regimen, they aren't showing any evidence of ARIA? Is that considered adequate information to hit the green light?
That's a really good question. So they're typically getting MRIs periodically every month or few months during the first 6 months of their infusions. However, I don't know that having had a negative MRI that you couldn't then develop ARIA afterwards. I think it helps give you some information to maybe inform that shared decision making, but I don't know that it's definitive that, oh, if you didn't have it on your last scan, you don't have it now. Certainly, as time goes on from after the infusion, you're less likely to develop it after those first 3 to 6 months of treatment. But we still don't have a lot of information there. I would say one thing we could try to do is if you have neurointerventional approaches and it's a large vessel occlusion, you could try to prioritize those interventions as opposed to your thrombolytics.
Now you mentioned, here one of the things is, we're talking about actually stroke, and then, potentially weighing this in terms of getting this for stroke. But, occasionally you mentioned the numbers aren't huge, but the ARIA itself can be symptomatic and can present in the acute care setting. Kind of roll us through that presentation and considerations when they come in there. And is it something that's just going to look like another stroke or a
Hmm.
stroke type syndrome, or is it going to be something that's going to have other manifestations that we can, from an exam and history standpoint, say, oh, this could be ARIA?
So ARIA can, again, most of the time it's asymptomatic. That's why it's, you know, just found on, it was termed an imaging abnormality rather than like a symptom or syndrome. But when it is symptomatic in those 1 to 7% of patients receiving these monoclonal antibodies, it can have very vague symptoms. So I know this is going to be even more unsatisfying. So it can be things like headache, gait instability, confusion, dizziness, vision changes, nausea, aphasia, weakness, seizure. So some of these could certainly mimic a stroke. Your aphasia or gait instability, that could mimic a stroke. Some of the other ones, the nausea or seizure, are maybe less looking like a stroke. And it can also potentially look like PRES, posterior reversible encephalopathy syndrome. So when they come in with these symptoms, we should ask about if they're on a monoclonal antibody treatment, but we need to keep in our differential things like ischemic stroke or hemorrhagic stroke or meningitis or encephalitis or PRES or toxic, metabolic encephalopathies or maybe seizure for other reason or a post-ictal state. So often if you have MRI, that's going to be the best way to differentiate, is this ARIA versus something else like PRES?
And what is the management if somebody comes in and we finally, Lord willing, a meteor strikes and we somehow get in the emergency department a diagnosis of an ARIA related presentation? What are the management options, treatment options for us in the emergency department?
So it's not something that's, emergent, like, oh, we've got to start this in the next 90 minutes. So we typically will have time if we think, okay, this is not a stroke, this is ARIA. If you have a neurologist available, I would talk with your neurologist or your teleneurologist. You've gotten your MRI, you can monitor them. The management, the thought is currently IV steroids, so methylprednisolone for moderate or severe ARIA. The dose is very much under debate. Some guidelines said 1 gram IV a day, but then they're currently revising those guidelines. That may be too much. And so it is still TBD. But essentially, it's monitoring symptom control, treat their nausea, and then IV steroids. But I would do that mostly in discussion with a neurologist. So I would transfer this patient to a place that has neurology.
Now, is this something that, let's say we're in community, 85% of our docs practice in a community setting. They're
Hmm.
not in an academic setting. Even academic settings may not have ready access to MRI 24/7,
Hmm.
but at least you theoretically have access to a neurologist. With between teleneurology and then just some facilities that don't have any access at all, and then much less access to an MRI machine. Is this something that if somebody is on these medications, if you can determine they're on these medications and they have any type of weird or potentially neuro presentation, of going ahead and getting them transferred even without a definitive or leading diagnosis at that point?
I think that is reasonable. So if somebody is on these medications, especially the first few months, and is having these nondescript symptoms, you've ruled out maybe some obvious things, and you're left with this is probably symptomatic ARIA, especially if it's moderate to severe, then it would be worth transferring them to a place that has an MRI. Now, I will also say if they are getting these treatments, they must be living or at least within traveling distance of a clinic that gives them, which means they're at a place where they can get MRIs regularly. So most of the time, at least currently, you're not going to be getting these, medications by mail order. They have to be living in a place or have access to a place where they're at a clinic managed by a neurologist. They're getting regular follow-ups, they're getting regular infusions. So they're probably somewhere at least close to an urban or academic center.
This sounds like a great opportunity for our EMR and AI people to be able to flag us and let us know that we don't have to go dumpster diving for some weird medicine that I don't know how to pronounce. That there is a treatment plan in place that includes something that could completely screw me when I do my usual stroke workup.
Right.
But so if you're listening from an EMR and AI out there, make it happen. Um, Stroke's not our only diagnosis, and that we may consider thrombolysis. We may look at thrombolysis. It's rare, but we look at it for other things as well. And one of the bigger ones is going to be pulmonary embolism. And we see a fair number of those coming in. What are the considerations with these treatments, somebody coming in with a PE? Because now they don't necessarily have a neurologic deficit. So I'm not necessarily thinking about stroke. I'm not necessarily thinking about
Hmm.
anti-amyloid antibodies. What are the considerations with regard to other situations in which I may be wanting to consider thrombolysis?
Yes. Oh man. And now we're going to involve not just our neurologists, but our
I'm just putting
cardiologists
this
or
out there
pulmonologists. Yeah.
that anytime I hear Dr. Shenvi, big give sigh, a big, I know that the answer is not going to
The
make my
answer's
community work better.
the answer is not going to make you happy. I'm sorry, Ryan. So for massive PE, by the time we're thinking thrombolytics for a massive PE, the patient is pretty darn sick and unstable. So here's where we need to do some risk benefit calculations. If I'm coding somebody who I think has a massive PE, there's no question. I'm going to give the thrombolytics because they are in cardiac arrest, and this may be our Hail Mary life-saving option. If they have a semi-stable kind of massive PE, then we have to consider the risk of intracranial hemorrhage, especially if their last dose of the anti-amyloid therapy was within the last 3 months. So if I have access to other things like catheter-directed therapy or surgical thrombectomy, then I may want to try to push for that more if I can. If we need to use thrombolytics, then we need to just have a risk benefit conversation with the patient. Hey, you have a big PE. I'm worried this could kill you more approximately. However, because you're on this anti amyloid therapy, you have a higher risk potentially of intracranial hemorrhage. Yeah, somebody with a massive PE who's unstable, I'm not sending them to the MRI machine to get an MRI head. That's going to take several hours. And a challenge here, too, is if we bring in our interventional pulmonologists or other folks, cardiologists or whoever helps you with these types of decisions in your hospital, they may not be aware of ARIA or these anti-amyloid therapies. So it really is a lot of falling to us to make those decisions and have that risk benefit discussion. But if a patient is unstable, they could code at any moment from that massive PE. I'm going to explain the risks and benefits and make my recommendations to give thrombolytics.
That sounds like a great opportunity for emergency physicians too, is if you are aware that they're on this, or you get the word or are EMR people come through and give us a flag. Of informing the proceduralist that's going in to do that
Hmm.
thrombectomy, possibly thrombolysis infusion for these types of things, just letting them know so that they can do a little quick open evidence search and kind of get an idea of what the heck's going
Yeah.
on. But you mentioned the MRIs. All right, you mentioned, maybe they can or can't get the MRI. Now, we can get a stat MRI in our shop pretty quick. I mean, we whip them over there and they're done about 15, 20 minutes. But you mentioned earlier that this wasn't just run them past the magnet and give them the signs of the cross and move on and go from there. What kind of what kind of considerations or order do I need to put in to appropriately catch this type of the ARIA findings?
All right, so I'm going to tell you the acronym salads, and I'm going to fully disclose that I don't totally understand these. I just know that these are what we need. So if we're looking for, potentially a stroke versus ARIA, we want flare, we want DWI. I do know that's our diffusion weighted image, and we need either SWI or GRE. So our ARIA E, that's the edema, that is best identified on flare. Our ARIA H, that's our hemorrhagic, our microhemorrhages, that is best identified on SWI or GRE. And then if we're looking for stroke, that's we can see that with our DWI, our diffusion weighted imaging. But the key here is that CT will not show it. CT will not show ARIA, will not show your, ischemic stroke unless it's huge. And so we really need the MRI and we need the flare, DWI, and then SWI or GRE. And hopefully, if we're at a place that has more expertise or neuroradiology, if we put in, we're worried about ARIA versus stroke, they will know how to protocol it. But if they're not, that's what we want.
So any closing thoughts, any types of things now that you've got us perfectly scared once again of stroke when we were already numb to the stroke workups and the stroke alerts that were out there? Any closing thoughts with regard
Well,
to
let me give
ARIA?
you some reassurance, at least for some of the other things that you might be saying, wait, wait, wait. Okay, thrombolytics, big problem. What about just DOACs or other anticoagulation? So earlier on, the studies looking at these monoclonal antibodies, they excluded individuals who were on DOACs for, say, AFib or a DVT, et cetera. But now in more recent studies, they've included them, and no, patients are not all getting hemorrhages. So at least that is good. So if somebody comes in with a submassive PE or a DVT or, new onset AFib that you need to anticoagulate, routine anticoagulation with heparin or DOACs is thought to be acceptable and generally safe. You could still warn the patient, shared decision making. Hey, in theory, there could be a slightly increased risk. If there are signs of ARIA, though, that like headache, confusion, gait disturbance, then you may want to get a baseline MRI prior to anticoagulation if they're having those active symptoms, um, so that you can then say, all right, we're doing some shared decision making, and we should think about this prior to anticoagulation. But if they're asymptomatic in terms of neurologic symptoms, the general thought is that routine anticoagulation for DVTs or PEs is okay.
Really, at least that's one area of good news.
There's one area of good
Good.
news.
Yeah, we bring
So,
those people down all the time. I mean, they come down for their little DVT screen. It's a little
right.
pause, then we throw them on. Yeah. Especially
Right.
now with the expanded use of the DOACs for even smaller DVTs and the more extensive superficial. That's comforting that I don't have to go chart diving for these folks that hopefully you can get in and out from your lobby setting.
Right. So I would say the take home points here are patients may be on these monoclonal antibodies for mild cognitive impairment, and it may not be on their medication list. If they are getting them, we care especially if they've had a dose or infusion in the last 3 months. That's when they're at highest risk for all of these things. Most of the time, 10 to most of the time patients don't have any ARIA. 10 to 30% will have ARIA, amyloid related imaging abnormalities. Most of the time that's all it is, an imaging abnormality. It's not causing any symptoms. However, if they have an imaging abnormality and some need to get thrombolytics, now we worry about the increased risk of hemorrhage if you give them thrombolytics. So ideally, we want to get an MRI before we give thrombolytics. And if they have any evidence of ARIA, we want to try to avoid thrombolytics. If we have it, we can use directed approaches, go get that clot, retrieve the clot, etc. But if it's something immediately life-threatening, like a massive PE, they're unstable, or it is a really high NIH stroke scale, and we can't get an MRI, and this is their only kind of hope for improvement, then we can do some shared decision making, explain the risks and benefits to the patient. When we are making these decisions, if you have a neurologist available, I would call that neurologist early. Say, this is a patient who's on these anti-amyloid therapies, lecanemab or donanemab, and they've had an infusion recently, if you can find that information out, and I need guidance on how to proceed. So call your neurologist early and often. If you're getting an MRI, get it with that flare, the DWI, and then either the SWI or GRE in order to see the different types of ARIA as well as your ischemic stroke. This is also my final thought is this is a really rapidly evolving field. These medications are pretty recent that they were out on the market, but the number of individuals who are potential candidates for them is also growing. So it'll be interesting to watch in the next few years how these play out. I think the evidence for their benefit um, is modest. So we'll have to see how it plays out once more people are on them and how it really demonstrates benefit. You know, if you have cognitive impairment and this is an option and it gives you some improvement, absolutely makes sense to use what's available to you to protect your cognitive functioning. At this point, we don't fully know and understand or can quantify the risks of hemorrhage. So we're kind of walking a little bit blindly and having to tread carefully. So maybe in a year we'll do another podcast and say, now we have better data, but this is what we have at this point in time.
Well, you have to come back every year anyway, so you might as well. I mean, I think we're on about a 6 to 8 month. We go through little batches every
We're on a
six to
six
eight
to eight
months a
month
year.
cycle. Yep.
Yeah, and it works out great. I mean, it's
Perfect.
always a great guess. But you did mention, and it brought up one question before I wrap, of the timeout. You mentioned if they hadn't had a therapy within a few months, is there a time of which they're off the therapy or completed the therapy that we can say, even though they had been on these medications, we don't need to worry about it anymore. We don't need to dive into this.
So it seems like it's 3 months from the last infusion is when they're at the most risk, but potentially up to 6 months. My understanding is if they're 6 months out from the last infusion, they're probably, just fine, typical risks. But again, hold this evidence lightly.
Well, I mean, at least that's a little bit of good news that I don't need to for the entirety and the remainder of this patient's life, especially once they start getting into the more moderate and severe dementia presentations and can't give us the histories and context that they have of having to go in there and start to really do a deep dive into this type of thing. All right, so, and I'm going to try to find out the exact MRI order. I've got a neuroradiologist kind of looking on it. So if I can find it and put it in time, I mean, this, interestingly, if you're listening to this podcast and it's Monday, the week you may be listening to it the day we release it, the day I recorded it. So I'm going to release this podcast later today. So if I can get that information, I'll put it in the show notes. If not, I'll try to follow up and edit it later, edit the show notes later to get the exact order that you may need. I got somebody working on it right now. And so how can folks get in touch with you if they have any more questions? And of course, I assume you're giving a cadre a large number, voluminous amount of education and talks at ACEP 25. How can folks get in touch with you?
Yes, I would love to see you at ACEP 25. I have some really fun talks that I'm giving there. One that I'm particularly excited about on beyond work-life balance, seeking work-life efficiency. It is at 8 a.m. So I will put a plug in there. I would love to see you at 8 a.m. If you want to reach me, you can reach me at ryanastanton@gmail.com, and I'll be happy to answer any questions about ARIA, stroke, anything that you may have.
That's interesting. That sounds a lot. We have very similar email addresses.
We do, but in truth, cshenvi@med.unc.edu. Feel free to reach out and would love to hear from you.
Well, I appreciate it and thank you. And the good news is with Salt Lake City with ASAP 25, an 8 a.m. talk is much more achievable than an 8 a.m. Las Vegas talk, which we were last year. So, yeah, you can make it. You can do it. Her talks, information are fantastic. I also invite you. I'm going to be doing our ASAP or our Frontline Headliners series. It's a new thing we're doing this year where we're going to do it like a almost like a talk show feel where we bring some of our high-end speakers, and Shenvi is going to be on the 26th list, I believe, for coming in there. But this year we've got a few talks, including Amalma 2 and Olin Netteberg are going to be a guest as well. And so we're going to do that each day as part of the non-CME track. And really what we're going to do is we're going to dive into kind of how they got where they are, their background, who they are, instead of a medical topic, just kind of diving into these folks that you come to see at these conferences who are consistent headliners, and we're just going to dive into how they are. I think you'll be very fascinated in the three we have this year because I know their backstories anyway, and that's how it came up. And a little teaser that Amalma 2 was not originally into it for the EKGs. So
Yeah.
yeah, so
Yeah,
a
I
little
won't
teaser there.
spoiler that one. He's got a
Don't
great
spoil it.
story. And I would definitely put a plug in for listeners to go watch Olin Netteberg's talks at ASAP. I saw him speak last year, and oh my goodness, that man can talk and tell stories. I laughed, I cried. It was phenomenal. So please, please go and see whatever he's doing speaking. Just go listen to it.
Well, I kept trying to grab him last year for a podcast, and he was so popular that he never could make it to the booth. He would get grabbed and pulled all these different directions, and he's such a nice guy that I don't know that he was able to say, "Hey, listen, I gotta go." So we never caught up, and so I nailed him down this year by doing a frontline headliner. And so we're going to be there. Check those out; they'll be on the schedules, and we're looking forward to it. I think it's going to be a great new setting for our scientific assembly. The numbers are looking fantastic, so a lot of fantastic emergency physicians out there, and Dr. Shinvi, of course, a headliner. Very popular talks all the time, and I appreciate your time today talking about a reason to give me indigestion my next shift when the stroke's coming. So thank you.
Thanks, Ryan. Always a pleasure.
And as for me, you can contact me at my other email address that Dr. Shinvi gave you, or you can do the ASAP one, rstan@asap.org, rstan@asap.org, or at Everyday Med on X. Make sure that whatever your player you are on, that you are subscribed to the podcast so you get all the episodes. If you've never subscribed, I sure would love for you to subscribe and download every episode, which is nearly 600 at this point, because I don't look good on the stats. But also leave a review, a 5-star review, and things that you'd like to see or love about the podcast, because that'll help us out in terms of getting out and about to other emergency physicians around the country and around the world. So stay with us, stay tuned. I'm Dr. Ryan Stanton, and this has been some ASAP Frontline.